Doc, my patient is having high blood pressure. This is one of the most common phone calls we usually receive on the floor from our nurses. Watch to the end. I'm going to teach you how to respond to this commonly encountered patient problem on the floors. Whether you are a physician receiving this phone call or a nurse making this call, this video is going to be immensely helpful to you. The good news is the vast majority of the patients who have elevated blood pressure on the floors are completely asymptomatic and the rest of their vital signs are stable. On the other hand, a small portion of these patients is possibly having a life-threatening condition caused by the elevated blood pressure. These patients are possibly having what we call a hypertensive emergency. Early recognition and treatment of hypertensive emergency is crucial to saving the patient's life. For the sake of making things easy to digest and understand, this topic will be split into two videos. In today's videos, we'll discuss how to recognize and respond to a patient with a possible hypertensive emergency. And the next video will discuss how to respond to those with asymptomatic elevation in blood pressure. The moment a nurse calls me about a patient with high blood pressure, I reflexively ask three questions. What are the rest of the vital signs? Very important to know the full set of vital signs. If the nurse doesn't have them, kindly ask them to call you back with a full set of vital signs as soon as possible. Heart rate, respiratory rate, temperature, and pulse oximetry. Remember all of them, not some of them. The second question is the patient having any concerning signs and or symptoms. I will come back to what I mean by concerning symptoms or signs in a second. And the third question is whether the patient is pregnant and what trimester. Of course, I only ask this if the patient is a woman of a childbearing age. Now give me your attention here, please. If vital signs are abnormal and or the patient is symptomatic and or the patient is pregnant, leave everything and go assess the patient immediately. Your patient is having a hypertensive emergency until proven otherwise. On the other hand, if the rest of the vital signs are normal, the patient is asymptomatic, and the patient of course is not pregnant, then you can finish your bite or finish what's in your hands. There is no emergency here, and this is by far luckily the most common scenario you will encounter on the floors. And this will be the topic of our next video. Now back to hypertensive emergencies. If you read the textbook definition of hypertensive emergency, it is defined by the presence of a significantly elevated blood pressure and ongoing target organ damage. As you see, there is no specific threshold of how high the blood pressure has to be in order to call it a hypertensive emergency. What matters most is the presence of signs and or symptoms of target organ damage in the setting of a significantly elevated blood pressure, and usually it is an acute rise in blood pressure. But in general, most hypertensive emergencies happen when the systolic blood pressure more than 180 mm Hg and or diastolic blood pressure more than 120 mm Hg. It's very unlikely someone with a blood pressure of 155, for example, over 90 to have a hypertensive emergency. But you should always keep it in mind. So what are these organs when we say target organ damage? Here we are specifically talking about the following organs: brain, retina, heart, aorta, and kidneys. So any signs and or symptoms that is suggestive of the involvement of one of these organs is a concerning sign or symptom and should raise the possibility of hypertensive emergency if associated with a significantly elevated blood pressure. Now, brain involvement can result in a stroke, whether hemorrhagic or ischemic, subarachnoid hemorrhage, and hypertensive encephalopathy. Retina involvement can lead to severe or moderate to severe retinopathy. Heart involvement can lead to acute coronary syndrome and acute heart failure. And of course, aorta involvement can lead to aortic dissection. Kidney involvement can lead to acute kidney injury. Now, if you get called about a patient with a significantly elevated blood pressure with any sign or symptoms suggestive of any of the above mentioned conditions, go see your patient immediately. Your patient is having a hypertensive emergency until proven otherwise. So symptoms such as severe constant headache, confusion, agitation, seizures, visual disturbances, nausea and vomiting, or any focal neurological deficit in the presence of a significantly elevated blood pressure indicate a possible target organ damage in the brain. Symptoms such as chest pain and or shortness of breath indicate a possible target organ damage in the heart. Beware of myocardial infarction, MI, atypical presentation as well, like epigastric pain, shoulder pain, etc. Severe chest pain or back pain may indicate aortic dissection. Visual disturbances may indicate possible retinopathy, although most of those patients will not have any visual symptoms, and the only way to diagnose it is fundoscopy to look for papilledema and other findings like hemorrhages and exudates. A lot of us may not have the proper skill to look for those findings. That's why it is rarely diagnosed or recognized on the floor. For that reason, assume your patient has retinopathy if visual symptoms along with severe elevation in blood pressure. Now, target organ damage to the kidney may only lead to microscopic hematuria, but can be completely asymptomatic otherwise. I always rule it out whenever I'm dealing with a severely elevated blood pressure, regardless of which organ is involved. All it requires is a urine analysis and a CMP. Now, one thing we should always remember is that a mild isolated headache is a common finding when blood pressure is significantly elevated and not considered a symptom of a hypertensive emergency. So it's important to ask how bad or severe the headache is. Now, let me ask you this. What if you get called about a patient with knee pain or low back pain or abdominal pain or other kinds of pain and a significantly elevated blood pressure? Is this considered a concerning symptom? Always think, is the sign or symptoms suggesting a brain, retina, heart, aorta, or kidney involvement? If not, it's likely the pain is causing this elevated blood pressure, or at least contributing to it, not the opposite. This is not a hypertensive emergency, and likely the blood pressure will improve with better pain control. In such case, all we need to give is pain medication, not a blood pressure medications. Another possibly confusing issue we frequently encounter in real-life practice is, don't we expect an agitated or restless patient's blood pressure to go up? So how do I tell which one causing the other? Is it being agitated causing you to be hypertensive, or being hypertensive causing you to be agitated? Because the first is not a hypertensive emergency, but the latter, it is a hypertensive emergency. Remember here, agitation is not uncommon, especially in elderlies. It's way more common than a hypertensive emergency. It has multiple underlying reasons. So if a hypertensive emergency is causing the patient agitation, it's likely will cause other associated symptoms along with that, including headache, nausea, vomiting, and usually these symptoms precede the confusion and agitations. If none of these associated symptoms is present, it's better to look for other causes of agitation like hyperactive delirium, alcohol and drug intoxication, or withdrawals, rather than considering a hypertensive emergency. Now, based on the conversation with your nurse, you suspected your patient is possibly having a hypertensive emergency. You know what to do next, right? Of course, leave everything, put your sandwich aside, and tell your nurse you are coming right away. Please go and save your patient's life, and don't hesitate to call what we call the rapid response team if you have that in your hospital, especially if the rest of vital signs are unstable. Calling a rapid response team will speed up the response to the unstable patients by getting the personnel and equipment to the patient's room as quickly as possible. For example, in our hospital, this team includes ICU nurse, a respiratory therapist, an ER physician, an ER nurse. The crash cart will be brought to the room. The patient will be connected immediately to the crash cart and to the monitors, if not connected yet. And of course, you should be there. Now, the moment you enter the patient's room, stand in front of the patient's bed so everyone knows you are in charge. Make sure the patient is connected to the monitor and to the crash cart, and immediately proceed to check the airways, breathing, and circulation. The ABC algorithm, verify the accuracy of blood pressure measurements, check blood pressure in both arms if aortic dissection is suspected. I discussed the ABC algorithm in detail in my previous video, how to respond to a hypotensive patient. A link to that video is provided in the description field. Next, inform everyone you are transferring your patient to the ICU as soon as they are stable enough for the transfer. If for some reason an ICU bed is not readily available, a bed in the step-down unit can be adequate as long as the unit can provide the level of care your patient needs. So make sure to know the capabilities of each unit at your facility. Otherwise, the patient should not be moved except to ICU. Now, while we're trying to stabilize our patient, we should get a quick history from the patient if possible, or from the patient's nurse, and perform a quick focused exam, trying to identify what kind of a hypertensive emergency we are dealing with, and to proceed with the appropriate workup and blood pressure lowering strategy based on the suspected diagnosis. Obtain a non-contrast HIT CT or activate code stroke if signs or symptoms are suggestive of a stroke. It's important to mention here that hypertensive encephalopathy is only diagnosed retrospectively when the patient's symptoms quickly improve with the blood pressure improvement. Please do not delay stroke workup and treatment to see if your patient's symptoms will improve with the blood pressure control or not. Hypertensive encephalopathy is a diagnosis of exclusion. Obtain an EKG, chest X-ray, cardiac enzymes, echocardiogram, and blood pressure in both arms if there was a chest pain, shortness of breath, gastric pain, or back pain. Obtain a stat chest CTA if severe chest or back pain. This is aortic dissection until proven otherwise. In all, I obtain a CBC, CMP, and urine analysis. The CMP and urine analysis is to look for acute kidney injury and hematuria as signs of kidney or renal hypertensive emergency. Don't forget to perform a pregnancy test on childbearing age women, perform a drug screen if intoxication is suspected, and perform fundoscopy if visual disturbances and you have the skills to perform that. Please do not delay obtaining these tests, as some of these tests can be done quickly, including an EKG, chest X-ray, urine analysis, and blood work. Others like CT or MRI require our patients to be stable enough for the transfer. Also, guided by the signs and symptoms of the most probable diagnosis, we should pick the most appropriate blood pressure lowering strategy. Now remember this, in hypertensive emergencies, the goal is to drop the blood pressure by 10% in the first hour and then drop it by 15% in the next 23 hours. That is a total of 25% drop in the first 24 hours from the original value. It's easy to remember, it is 10 plus 15% equal 25, right? Now, does this apply to systolic blood pressure, diastolic blood pressure, or both? If both are elevated, it's better to use the MAP as your guide. If it is one of them elevated, you can use the elevated value or the MAP as your guide. Now, this rule, the 10 plus 15% rule, is valid in all hypertensive emergencies cases except for the following. The acute phase of ischemic stroke when thrombolytics are indicated. Here the systolic blood pressure should be lowered to equal or less than 185 mm Hg and diastolic blood pressure to equal or less than 110. And the blood pressure should be maintained at or below 180 above 105 for at least 24 hours after thrombolytics treatment to reduce the risk of bleeding. Now, if reperfusion therapy is not indicated, we don't treat blood pressure unless it is severely elevated with systolic blood pressure more than 220 or diastolic blood pressure more than 120. Only then we may follow the 10 plus 15% rule. On the other hand, in the acute settings of intracranial hemorrhage, things may get a bit confusing whether we are monitoring the intracranial pressure or not. But to make it simple, the goal here simply is to drop the systolic blood pressure to the range of 140 to 160 mm Hg, or a MAP, keep the MAP less than 110 mm Hg. This is in the first 24 hours. Of course, patients who deteriorate clinically during this period may require to stop or slow down their antihypertensive therapy. Now, the third exception is the acute aortic dissection. Here, the systolic blood pressure should be rapidly lowered to a target of 100 to 120 mm Hg within 20 minutes to reduce the aortic sharing forces. The fourth exception is severe hypertension in pregnancy. Here I mean systolic blood pressure more than 160 and or diastolic blood pressure more than 110. Here the goal is to drop the blood pressure by 25% within 2 hours. In general, the goal is to drop the systolic blood pressure to around 140 and diastolic blood pressure around 90. So again, let's repeat it. The rule: the 10% in the first hour and the additional 15% in the next 23 hours for all cases of hypertensive emergency except ischemic stroke, hemorrhagic stroke, aortic dissection, and pregnancy. Now, if two hypertensive emergencies exist, we go with the more aggressive blood pressure lowering strategy. Let's say our patient is having aortic dissection and stroke. In such case, we follow the aortic dissection blood pressure strategy. The following immediate consults should be called: an OBGYN consult immediately for pregnant patients with severe hypertension, a cardiovascular surgery consult for aortic dissection, a neurosurgery consult for intracranial bleeding, and a neurology consult for ischemic stroke. Please arrange for a transfer to another facility if your facility lacks these services. Although sometimes ischemic strokes can be properly managed by the internal medicine team, if not complicated, of course. The rest otherwise should be transferred after stabilizing them and initiating their blood pressure lowering strategy. Now, we have a diagnosis or a probable diagnosis. We decided on our blood pressure lowering strategies. Two questions here. What medications should we use and how do we use them? Before anything, I immediately check if the patient was on any blood pressure medications at home or not. If yes, did we resume his or her blood pressure medications on admission or not? If our patient was taking one of the short-acting agents, the withdrawal of short-acting antihypertensive agents, especially clonidine, can result in severe elevation of blood pressure, and simply restarting them can solve the problem. We still follow our blood pressure lowering strategy in such case. Now back to our questions about what medications should we use and how to use them. In hypertensive emergencies, we are mainly talking about IV blood pressure medications here. Oral medication should be reserved only for the case we just mentioned, and if for some reason there is no IV access and it is taking too long to place IV access, we can use oral agents if the patient is safe to swallow until IV access is placed. The following blood pressure medications are the most commonly used in real life practice: nitroprusside and nitroglycerine from the nitrates family, Nicardipine and Clevidipine from the calcium channel blockers family. Diltiazem here is mainly reserved for rate control rather than blood pressure control. Esmolol and labetalol from the beta blockers family, and enalaprilate from the ACE inhibitors family, and of course hydralazine. Nitroprusside, nitroglycerin, Nicardipine, Clevidipine, and Esmolol are all given as a continuous infusion only, given their short half-lives. Hydralazine is given as bolus injection only. Labetalol and enalaprilate can be given as a bolus or continuous infusion. Again, make sure to know what your hospital pharmacy has, and for exact dosing, check your references or you can ask your local pharmacist. There is really no need to memorize that. Now, patients with hypertensive emergency usually require a continuous infusion of blood pressure medications to tightly control the blood pressure, so we follow the chosen blood pressure lowering strategy. Now, whether we start with a bolus injection followed by a continuous infusion or directly start the patient on a continuous infusion medication, it doesn't matter. But sometimes we cannot start a drip until the patient is in the ICU, which may take some time. In such a case, we can use the scheduled bolus injections until a drip can be started. The two main medications used as a bolus injection in real-life practice are labetalol and hydralazine. Usually we give 20 mg of IV labetalol or 10 mg of IV hydralazine. As you probably know, the arterial line is the best way for accurate and continuous blood pressure monitoring and should be placed whenever possible. Use the cuff monitoring only if the patient or the arterial line cannot be placed for a reason or another. Now, let me go over the preferred medication guided by the specific condition we are treating. For pregnancy-related hypertensive emergencies, hydralazine and labetalol are the preferred drugs. Nicardipine can be used as a second line. Remember that nitroprusside and enalaprilate are contraindicated in pregnancy. For neurologic Neurological hypertensive emergencies, Nicardipine, Clevidipine, Esmolol, and labetalol all can be used. Avoid nitrates, the nitroprusside and nitroglycerine, as they may increase intracranial pressure. For cardiovascular hypertensive emergencies, the choice of antihypertensives depends on the specific condition causing the emergency. In acute heart failure, of course, nitroglycerine is the preferred agent. Nitroprusside can be used as well. In acute coronary syndrome, of course, beta blockers like Esmolol and metoprolol are preferred. Clevidipine and Nicardipine can be used. Of course, nitroglycerine can be used as well. In aortic dissection, beta blockers are the first line treatment, preferably Esmolol. Labetalol can also be used. Clevidipine, Nicardipine, or nitroprusside can be added to achieve the target blood pressure of lowering systolic blood pressure less than 120 within 20 minutes. Only after maximizing beta blocker therapy. Always maximize beta blocker before adding a vasodilator, and never use a vasodilator alone. For renal emergencies or hypertensive emergency or hypertensive retinopathy, calcium channel blockers such as Nicardipine, Clevidipine are the first choice. Esmolol and labetalol can be used as well. To sum this up again, Clevidipine, Nicardipine, Esmolol, and labetalol are the ones to go for in neurological hypertensive emergencies, renal emergencies, hypertensive emergencies, and retinopathy. Nitrates are the ones to go for in heart failure, unless of course we are dealing with a right-sided failure, which is very unlikely in the settings of a hypertensive emergency. Beta blockers are the ones to go for in acute coronary syndrome and aortic dissection. Now, don't hesitate to add a second drip or a scheduled bolus medication to achieve your target blood pressure if one drip is inadequate. The second medication should ideally be from a different class of medications. For example, if we started Clevidipine and needed another medication, don't add Nicardipine, as both belong to the same group of medication and have the same mechanism of action. Add Esmolol instead. Now remember the following: bradycardia is the main limiting factor to using beta blockers. I usually stop them if the heart rate sustains below 50. I usually like to start them with the heart rate above 60. Sometimes if it's in 50, I can use it with the close monitoring. All vasodilators can cause reflex tachycardia. Usually the rate is in the low hundreds. The main use of hydralazine is in pregnancy. Nitroprusside is rarely used these days. It's falling out of favor. I cannot remember when was the last time I've seen it being used. We have safer, more effective, and cheaper alternatives nowadays. If alcohol or drug withdrawals are suspected to be the cause of the elevated blood pressure, benzodiazepines are the drug of choice, of course, not blood pressure medications. For severe hypertension due to increased catecholamines activities like in pheochromocytomas and acute intoxication with sympathomimetic drugs like cocaine and amphetamine, phentolamine can be used. Phentolamine is an alpha-1 blocker that can be given as a bolus injection only, and it's used solely for the treatment of such cases. Now, as you may be aware or have read before, beta blockers or mixed alpha-beta blockers are considered contraindicated in such cases. Actually, this may be outdated. There is an ongoing debate about the safety of using beta blockers, and some strongly advocate the use of beta blockers, especially in the settings of cocaine-induced acute coronary syndrome. I highly encourage you to discuss this with the cardiologist who's consulted for that specific patient if they were having cocaine-induced acute coronary syndrome. Now, the patient is started on a continuous infusion of a blood pressure medications. Do we stop there? Do we leave the patients and that's it? Of course not. It's essential to closely monitor the patient clinically and to monitor the pace of drop in blood pressure to make sure it follows our chosen blood pressure strategy. Hopefully by now the patient has an arterial line. Slow down the infusion rate or shut it off completely if the drop is too quick. On the other hand, increase the infusion rate or add another class of medication if the drop is too slow to match the pace, of course, of our blood pressure lowering strategy. It is recommended to start new oral blood pressure medications or restart or adjust their original blood pressure medications within 24 to 48 hours unless the blood pressure is elevated secondary to blood pressure medications withdrawal like clonidine. Then we start it sooner but still follow the 10 plus 15% blood pressure lowering strategy. In the end, if you found this content helpful, make sure to give it a like and share it with your colleagues. Thanks for watching and I'll see you next video.